Thank you. Good morning to everyone and welcome to panel this morning. This meeting is being held electronically. Members of the public may attend this meeting in electronic capacity, and there is a link on the Council's website for them to do so. Members of the panel are asked to keep their microphones switched off until called to speak, and to switch their microphones off once they have finished speaking. Cameras may be left on throughout the meeting if members wish. If you experience connection or other technical issues, it may help to switch your camera off. Cameras should be switched on if and when speaking in the meeting. To indicate a wish to speak, members should use the raise hand function. Use of the meeting chat function is exclusively for voting, and that'd be much appreciated. At the end of the debate on each item of business, there'll be a vote. Members should vote using the meeting chat function by indicating for, against, or abstain. I will declare the result after each vote. Breaks of at least 15 minutes will be held every 2 hours and will be taken after a speaker in the debate has finished speaking. If we are voting, the vote will be concluded before the break is taken. Other breaks will be incorporated as appropriate. I'm going to move now to membership changes. Councillor Rena Ranger is substituting for Councillor Peter Hebden for this meeting only, and thank you. And Councillor Colette Whitelow is substituting for Councillor Fiona Guest for this meeting only, and I thank you both for your time this morning. Apologies have been received, none that we are not aware of. I'm going to now ask members of the panel to introduce themselves, starting with Councillor Barnard. Hello?
Yeah, I'm sorry, I'm still having a bit of trouble.
I understand, just take your time.
But it is me, Councillor David Barnard, for Hitchin Rural, and good morning, everybody.
Thank you, Councillor Barnard. Councillor Bell.
Good morning, I'm Councillor Nigel Bell. I'm the Councillor for West Watford.
Councillor DeCourt.
Good morning, I'm the County Councillor for Harpenden North East.
Thank you, Councillor DeCourt. Councillor DeCourt, your mic is quite low, just to let you know. Councillor Greensmith.
Morning, Leslie Greensmith from Goss Oak and Berry Green.
Thank you. Councillor Horner.
Good morning, Calvin Horner, Councillor for Bishop Stortford East.
Thank you very much. Councillor Kingsbury.
Councillor Tony Kingsbury, Councillor for Welling.
And Councillor Ranger. Thank you, Tony.
Councillor Rena Ranger, Councillor for Rickmansworth East and Oxley Park.
Thank you so much. Councillor Thake.
Councillor Richard Thake, Nebworth and Codicut Division.
Thank you, Richard. Councillor Tyndall.
I'm Councillor Ron Tyndall of Hemel Hempstead, St Paul's.
And Councillor Whitelow.
Good morning, everybody. I'm Colette Whitelow, and I represent Hemel Hempstead North East, better known as Grove Hill and Woodhall Farm. Thank you.
Thank you, panel. Thank you for that introduction. Moving on to the members' interest, have we any pecuniary interests or declarable interests to note this morning? Disposable or declarable? None noted. Moving on to part one of our open business today, inviting the panel to agree the minutes of our last meeting of the Adult Care, Health and Wellbeing held on the 10th of February. Could I ask you to vote via the chat? Just having a bit of a screen issue here. I'm just going to go onto screen. Agreed. Minutes of the 10th. Thank you. Minutes of the 10th, noted and agreed, of the 10th of February. Item 2 on the agenda this morning is public petitions. We have received none to date. So I'm going to move swiftly on to agenda item 3, Adult Care Services COVID-19 update, the ongoing risks, mitigations and our recovery. Helen Monroe, our Operations Director, is going to open the report to be noted for us this morning. Thank you, Helen.
Thank you, Chairman. Good morning, everybody. I'm Helen Monroe, Operations Director for Older People Services. I have done a few slides, so hopefully I will be able to put them on screen now. Just to summarise, I think, the key details in the report. Chairman, have they appeared, those slides? Yeah, they have. Good, thank you. Yes, there's a lot of detail and content in this paper, which really I think serves to give a kind of stock take really of where adult care services is right now as a department as we come out of the challenging winter period. And if members of the panel recall, I came to panel back in November with a plan setting out what we were going to be focusing on over that winter period from an operational perspective. And at that point in time, we weren't entirely clear that we would be hit by a further COVID wave, the Omicron wave. And so it was actually really helpful to have done all that prep and all that thinking, because that stood us in good stead, I think, as we worked through the challenges of that winter period. So the report kind of gives you an update on the things that we were focusing on during that period. And it also then says, well, actually, you know, we're hopefully coming through that phase now, or emerging into a new era of living with COVID, and how do we see the risks that we now need to tackle as an adult care services department, and what are some of the mitigations and changes that we need to take forward given that challenging outlook. So this is the sort of picture really of where we are with outbreaks, because that's been one of our key challenges, has been supporting our care providers as they work through outbreaks with infection. And in the paper, I think there is a version of this graph which is on the right hand side of the slide pack. And this version here I've just put in today, which takes it right up to where we are now on the 21st of April. And so this is a graph of how outbreaks and infections have affected residents of care homes, have affected staff working in those settings, and you know, how many outbreaks in total we've seen. And it takes you through the entire 21-22 financial year, really right up to date. And you can see that, you know, during the first part of the year, all of those lines, the grey line, the orange line and the blue line, fairly flat, little bits of bubbles now and again. But then we had the sort of significant impact right at the start of this current year. So 6th of January, that grey line representing the number of staff infected with COVID, right up there above 500. And then that came down a little bit, but then peaked again around about the 25th of March. But I think the important thing for me is we are starting to see that March peak now falling away. So that's encouraging. And now we have the outbreaks, the orange line at the bottom, the number of settings that have got an outbreak currently, again, starting to dip down again, which is really positive for us, both in terms of obviously a safer setting for people, but also, you know, the demands on the service of working to support homes as they're working through those challenging outbreak scenarios, you know, lessen the fewer outbreaks that we have. So it's positive to be coming through that period now. So in terms of the report before you today, let me just try and move this second slide here. A summary of the kind of key things we've been doing over the winter. So obviously outbreak support has been top of our agenda, as has a sort of operational preparedness to respond. And so lots of work to support providers and make sure the the sort of in-house provision and also our professional staff who carry out assessments and support have been ready and prepared, and that we've been able to respond as and when we've needed to support continuity of services. We've been also doing a lot of work to support with additional service capacity. So at times we've needed to support hospitals, particularly where they are under pressure with trying to manage the flow of patients through those hospitals. So we've been responding to help them. We've been making sure we've got sufficient capacity in our services to receive people coming out of hospital in particular. We've been doing a lot of work around workforce. I think the panel will recall back in December we brought a paper which signalled that we were able to offer a retention bonus to care workers who work in services that are commissioned by the County Council. So that was a big a part of our winter response to make sure we were retaining as many care workers in the system as we possibly could. We've also had the complexity about the proposals to introduce mandatory vaccination to the domiciliary care workforce. Those proposals were rescinded before they were actually implemented, and also the proposals that mandated vaccination in care settings in residential and nursing care have now been revoked. So that's good in terms of we understand where we are with the vaccination question, but it has meant a lot of work during the period to manage and support providers to prepare for that vaccination effort. We have been supporting people and we've been supporting carers, so lots of detail in the report about additional support for people who are struggling during the winter period. How we've been advising and informing people about things they can do to stay safe and well during that winter period. Lots of support for carers in terms of carers short breaks, and we've been trying our best to keep open services, day services, etc., reopen them, keep them open, because we recognise how vital they are for supporting carers and people who use those services. And then in terms of the care providers, the deliverers of domiciliary care or care homes themselves, an awful lot of support, both financial support and support with information, advice, guidance going out to that whole sector. Just totted up quickly this morning, more than £34 million distributed to that setting. Additional money really coming through from government around things like support with infection prevention, infection control, workforce support. So lots of work to do to be on the front foot. Jackie, I can see Jackie on the call. She's been, making sure we distribute that funding as quickly as possibly can when we get new tranches awarded. So that's been a real feature, and we've continued to maintain the hub, the information hub for providers during that period. So I think, in total, I hope a good winter response, and I feel like we've navigated that really challenging period with relative success. So looking ahead, just wanted to pick out some risks that we face as a sector, as a service right now. I don't think these risks are in any way unique to Hertfordshire. Looking out into the wider landscape of care provision and the providers that we work with, we have seen during the year just gone one or two providers who have had to close their businesses. My view is that we may be hit by more of that in the year ahead. I think we've seen a lot of additional funding, as I referred to, come into the market during the period, and now those additional funding streams are coming to an end. So we've got, a significant difference really in the amount of funding provision that's entering the market, and I am in no doubt that will have impacts. We've also got the workforce challenges which are ongoing. Providers have had a lot of work to do to get their heads around changes in guidance, so it's been a very difficult context for them to work in. In terms of how we're supporting providers, so in green there, continuing that work with the hub, the information and advice. Our commissioners very carefully and closely monitoring provider failure risk in the market and making sure we're in there proactively supporting. And then we've been doing our best to really support providers with some short-term certainty as best we possibly can around funding. So we've got some plans in place to look at how we manage hospital discharge funding and the changes there that we're going to see. And we've been able to offer for the month of April some short-term support for providers to see them through that sort of post-Omicron wave around infection prevention and control. So stepping in there as a council to offer a little bit of continuity. Workforce remains very challenging, talking in the paper about the pressures on workforce, both recruitment and retention, and that's not only in the wider care workforce out there in the market, but also in terms of the County Council's own workforce, and lots of work that we will need to carry on doing around that. So supporting wages in the market, but also internally around our recruitment. We want to explore different opportunities around overseas recruitment and, in terms of thinking about what makes the council as a social care authority a good place to be and to an attractive employer. I think, continuing our really high quality L&D offer and paying a lot of attention to colleagues' well-being as they, come through 2 years of quite intense work. Around demand, so that does present significant challenge for us as a department, and we are seeing continuation of high levels of demand. That demand is more acute, more complicated, more complex, so more challenging to meet. Certainly we see the hospital pressures continuing, and we've got a key role to play in supporting those hospitals with getting people out once they're fit and well. So lots of work to do as the hospitals work through their own backlog of treatment and operations. We've got people at the moment waiting. We have people waiting for a home care package. Got a graph in the paper around that. I've reproduced it there. It's important to get below the headlines though. So a lot of those people who are waiting are actually cared for, have provision, or are in hospital. So important to read the details there. And we do have people waiting for assessments. And again, that's been, I suppose, a combination of that demand level and the need for our staff sometimes to have to do other activities than assessment as we have worked through the COVID winter period. And then in green there, what we're doing about that, we've got some additional resources coming in to help us work through those backlogs so we can go out and get some new colleagues to come and support us with that work. Sorry, I've nearly finished. I've got one more slide. We're looking at commissioning strategies, particularly around the home care market and how we can increase our capacity there by attracting more providers into the market. And we've got some significant plans around transformation. And members may recall in the budget, we had some additional investment going in around prevention. All that's about how we redesign what we call our front door, where people come to us and ask for care and support. Can we have better prevention conversations at that point in time so that we're keeping as many people away from needing ongoing formal care and support as we possibly can do. Final slide for me then, just to summarise, I feel like this report hopefully sets out that the department, the service has navigated this most challenging winter with relative success. I think key to that has been, the experience that we've had over the last 2 years where we've worked through significant COVID-related issues and we've built that learning now well into our responses. We as a department and as an adult social care sector are now emerging from the COVID phase that we've been in into a new phase where we have to learn to live with COVID. What does that mean? How does that affect our providers? The guidance that we give, all that needs quite a lot of thought and working through. And I've set out some of the risks and challenges I think we're looking at as a department and how we're planning in high level terms to meet some of those. Thank you, Chairman.
Thank you, Helen. Thank you for that presentation and thank you for your report and also for your ongoing commitment to adult care services. We have questions in the chat. I think I may have frozen there for a moment. Ron, you had your hand up first. Would you like to ask your question?
Thank you very much, Chair. First of all, could I express, I think, the think there's common view of all of us that a fantastic job performed by everybody in adult care services throughout the winter and coping with everything that's been thrown at them. And I think everybody deserves a big thank you from all of us to all of you. So having said that, I'm particularly interested in the future going forward, particularly in the care providers, because I believe that's where our greatest risk lies. And my screen's just gone blank. On the top of page 22 of the pack, there is a reference to a situation, and I've lost the reference. The situation in the top paragraph, given by the delays in guidance and living with COVID, and also then the following bullet point refers to all the various measures that support providers coming to an end nationally. And I know Helen has already referred to the risk of provider closures, but I just wondered whether or not we have any opportunity of looking towards providing some support to fill that hole that's being left by government, or whether or not we are going to have to struggle through the next 2 or 3 months without additional support.
Thank you, Councillor Tyndall. I'm sure Chris might want to come in. In terms of the uncertainty, when I wrote this report, which was, I think, about 2 or 3 weeks ago, we didn't have the clarification from government on the next phase of COVID guidance for care providers. We did get that just on the eve probably of this being published, this report. So we do have now some clarity about what the rules and regulations are about how providers are going to support individuals. And I think the change, I suppose, is that, you know, a little bit more on providers, a little bit more responsibility on providers to risk assess and use their judgment as and when you know, there's a question of perhaps supporting someone who may be at risk of being infected. So a lot of changes, a lot of differences for providers to get their head around, and they remain, you know, sovereign at the end of the day and can make a decision. If they feel it's safe to support a resident back, they can do that, or they can say no, that person must remain in hospital, for example. So a bit of a change, a bit of a sea change. Changes around visiting guidance, more permission now, which is really welcome. You know, much fewer restrictions on the visiting arrangements in care homes. So we're really pleased to see that. In terms of supporting providers with the challenges, I think probably funding wise, that's going to be a challenge for us. We did manage, as I said, to secure some short-term support for the month of April. We've got some work that we've done with National Health colleagues around some of the changes where we've been able to buy additional care capacity in the market. We've got some transitional arrangements there. So there's a little bit of tiding over that we can do, but we've got to really start to think about how we plan for that post-COVID world, and a world where we don't have as much additional funding coming in. So I think that's where the challenge lies. And for us, it's, you know, really careful monitoring, really close conversations with providers so that we can anticipate any issues that we might need to help with. I can see Chris has sort of got his hand up, so I'm sure.
Could I just add, Helen, that I'm particularly concerned about workforce and those that catch, because COVID still seems to be fairly prevalent, and people who catch COVID having to sort of have a week or two off or whatever, and if there isn't the support measures going forward, whether some of the providers may struggle to continue to, you know, to pay staff if they've then got to pay agency workers or some other means to cover the gaps.
Yeah, I'll hand to Chris, I'm sure.
Chris, would you like to come in on that question?
Yeah,
more than a question.
Yeah, I think what I play into the mix here is, yeah, clearly we've got a load of funding streams that are coming, you know, offline and kind of weaning people off them. in that mix is also unprecedented, certainly in this generation's inflationary pressures, which will impact particularly at the lower end of wage scales and therefore care providers. So we are, clearly entering a period of significant uncertainty for providers, and we'll have to keep a really close eye out on that and look at monitoring risks. We do that with our intelligence. We piece together lots of bits of intelligence to do that. So we're keeping a very, very close eye on quality of providers, financial health, workforce pressures, and looking at that all the time because, clearly we're going to see both COVID-related pressures, cost of living related pressures impacting, and care reform coming next year. So we're going to have to be quite nimble about looking at those risks. And one of the reasons for getting Helen's report there was just to flag those risks early and be clear what we're doing about them. So yeah, agree, Ron.
Thank you. Thanks, Stella.
Yes, thank you, Chris. Nigel, you have had your hand is up.
Yeah, thank you, Chair. And can I echo Ron's words of support and thank you to all the staff, and clearly for everything they did. And clearly Helen, when she came in November, was a woman with a plan, and it's largely worked, but all the other staff as well. But can I just go back, slightly linked to well, a bit of what Ron said, but yeah, concerned about COVID still being there and how staff will cope, but also really looking at staff retention. Obviously grateful to the extra money that came from government that was put into the living wage, the sort of minimum wage, living wage, etc. But can you give an estimate maybe of what, maybe it's Chris, I don't know, of what we'll maybe have to need in the next year or even the next couple of years, because clearly staff retention is going to be a big issue again. And, as you just mentioned, inflation will be 7-8%, could be more. So what are we likely to have to need? Can you give maybe a figure as to what we're only going to need above and beyond what we've had to put in this year? Thanks.
Nigel, are you talking in terms of funding or people or numbers?
Sorry,
or
well,
both?
you could say both, but people really. I mean, the pay, obviously the bonus that was put in, which is welcome, the £600. But I mean, they're basically keeping for the 2021, 22, 23. But we obviously need to look forward as well. So in the next couple of years, we know that it's £10.30 living wage, and what is it, £13.83. To local providers, but can we make an estimate as to what we're going to perhaps, especially with inflation now, going to have to need in the beyond that?
Yeah, I mean, I suppose it's hard to make an estimate right now, but certainly, we're in pretty regular dialogue, or we're in very regular dialogue with HCPA, who represent the wider market, and they've been feeding back to us already that they are experiencing cost pressures. I feel like we need to keep a really close eye on that. We've got the energy prices and workforce issues, and we'll be just gathering as much intelligence as we possibly can to support when we start to think about budgets for the year ahead. I think the other interesting thing, and I don't know if Chris or Jackie would come in on that, but that we've got this what's called fair cost of care exercise that we'll need to do as part of care reform, and that's really asking us to work closely with providers for them to share some of their cost pressures, how they model their businesses, and so that we've got even better insight and intelligence than we already do about that, and are able then to think, well, actually, to what extent do we have a gap between what we pay as a council and what a fair cost of care looks like? We may have in some areas, we may be on the money in other areas, and then if we do have a gap, how do we plan to progress towards meeting that? I can see Chris has got his hand up. So.
Yeah, it's a really good point, Nigel. And I think what we need to think of when we talk about social care inflation, we're talking particularly around the impact that increases to the national living wage will have, because that's essentially what drives what we need to pay people. Even if we pay them above that, we need to peg it to that national living wage. Government have consulted on a kind of broad set of sort of ranges for what that might look like in 23, 24. And that kind of needs to be one of our central planning assumptions around what the impact of those wages will be there are going to be some numbers around inflation that we're not used to, albeit there was a significant number in this year's IP. We'll have to adjust that. We're working with finance colleagues to look at what ranges that might be. For care providers, their big costs are staff and often energy. Now, those two are clearly going to be going up probably over and above what the kind of headline rate of inflation is, because those are the two issues that are likely to be driving bigger increases in inflation than the overall average. So yes, it's something that we're having to look at now. What we're doing is looking at it immediately, not waiting for the budget process as would be normally scheduled, but looking earlier, because that issue is clearly one to do. But we're also going to need to be with local government association and other bodies, making sure we're making this case very strongly to government in terms of social care funding, to ensure that those inflationary pressures are certainly understood and recognised.
Okay, thanks. You noted it. Thank you.
Absolutely, Chris. Paul.
Thanks, Tom.
Thank you, Nigel.
Thank you. I've got three things. The first one actually just been covered a lot by Nigel and Chris's conversation, but just take it just a fraction further in terms of retention bonuses. I just wondered, did we have any evidence of the success of that? I don't know if there are any comparators with turnover of staff prior to this or with other authorities.
The success of the retention bonus.
Yeah, it may not be something to answer now, but just
I'm quite sure that is a positive. But Chris, would you like to speak to that?
Yeah, and Helen may chip in. It's a good question, because obviously if we can evidence it worked, then it's a good case for investment. I suppose I had lots of feedback about it. Always some challenges about where did you draw the line and so forth. Whenever you do something like that, it's actually you're drawing a line to about who doesn't get it, how much is it, the impact of national insurance on it. I suppose, Paul, what I would say about the retention bonus, and we'll probably be able to look in 6 months' time when we compare with other areas around retention, is how do I say this in the right way? We managed to keep operational resilience of care providers and reduce significant provider failure during the winter that we've just had. That's not to say pressures have gone away, but there were acute pressures in the winter, and the fact that we were able to keep going and keep supporting partners around discharges, stopping places, feeling the effects of sort of staff shortages that perhaps was felt in the first couple of waves, means by hook or by crook we got through, and I think that would have been one of the ways that helped. I think we'll have to look over the next 6 to 12 months about how we are on the vacancies in the sector compared to comparable other areas, and to see if perhaps we're ahead or behind of what others did. At that point, we'll be able to draw a correlation, not necessarily a causation between the two, but it will give us a good sense of what that looked like. In addition to, well, what are our underlying wage rates compared to what other authorities? So it's going to be quite difficult to sort of disentangle. But what we may consider doing is doing some work with HCPA around sort of surveying providers for a bit of qualitative impact and view, because they'll give us a sense of how that went down. Because if we wanted to do it again, how could we do it differently? What's their kind of anecdotal view on how effective it was in their own businesses, and perhaps that's something we could look to do over the next sort of few months when some of the current pressures have hopefully lessened a bit. So I think that's actually a helpful steer.
Yeah, thank you. Because my observation would be is if it has been successful, and I think it's likely it has been, that's the good news. But the bad news is that if the underlying economic conditions don't change, we'll be reaching with that or something similar again. And obviously you're preparing for that, so that's excellent. My next question was sort of linked. So we talked about provider failure quite a bit. There's reference in 5.2 of the document about, I think it's the last bullet there, about 23 providers handing back care packages. I think it's 127 people. And I think I understand now where they've gone. They've gone to some of your larger providers. They've been transferred largely to some of your larger providers. I just had a question about, are we seeing any new providers coming to the market, or is this always going to be a net loss and therefore a consolidation around these biggest providers?
I mean, I think actually the share of the market that the biggest providers respectively have between them, it's probably not as big as you may think. I don't know, it's probably, I don't know, 20+%. So there is a very healthy, what we call spot market, with lots of providers in, and we've got these 3 lead providers that we call. So I think one of the things that we're doing to try and encourage that spot market and to make sure it's as healthy as possibly can be is to have a framework exercise where we're encouraging providers to bid onto our framework to come and work in Hertfordshire, an opportunity really to set the prices that we want to work with those providers at, if we possibly can attract them for those prices. So lots of work ongoing in commissioning to sort of really reach out and try and shape that market. I think we're, they're a very important part of our landscape, really, those spot providers that we need to work hard with, and hopefully we may have 1 or 2 future lead providers amongst them who we can develop, because, we really need a healthy amount of choice in the market in order to make sure we've got good resilience, basically. I can see Chris wants to come into.
Yeah, so we have, thanks. So overall, we have 69 home care providers that we work with. And the net growth over the last year has been 4. So we've gone up by 4. So we've made up for those that we've lost by new entrants to the market, Paul. You'll see that while we've had providers sort of hand back, sometimes they hand back some packages, but not all. So we still contract with them, but at a lesser level. Others just stop, working or move on to do different bits of business. But overall, that market has grown by 4. And as Helen said, the framework to deliver more providers is ongoing. Clearly, we're in a better position because of the investments we've made in home care, because of the strategic value we place on home care as the kind of best way of supporting people at home with care needs over the last 4 years, enables us to offer wages that are attractive.
Thank you, Chris.
Thank you.
Paul?
Can I just do my last question? It is a bit on a different area, but that'll be me done. It was just about the reference right towards the end of Helen's presentation, which was about living with COVID. This was a question for people with greater experience of mine in time of prior to COVID, and I'm aware of obviously seasonal flus impact on the care sector. But I just wondered, at what levels do we think this starts to look like seasonal flu, in the sense of we're aware of more winter pressures, but they won't be greater than what we've experienced, say, 5 years ago, excluding extra demand and excluding obviously a breakthrough variant coming through. But if we get that normality, are we starting to look a little bit like that when this latest outbreak, which is on the downturn, tails off as we expect it to?
Thank you, Paul.
Chris, in his previous role, probably had more experience of dealing with winter fever. I would say this is still different and still more significant in impact. Certainly, I would have thought for a couple of years into the future. I don't know, Chris, whether you've got any more insight on that.
Yeah, I mean, we've had some really difficult winters. I think what we don't know yet is the extent to which, one of the pressures that we've got at the minute is clearly because of the infection prevention control rules within hospitals and with care homes, is done to protect people, but creates a lot of inefficiencies because of different pathways and so forth. Some of that's been released over the last week or 2. So it's difficult to know how much of the pressures are the quantum of people, but also the efficiency with which they can be cared for and supported. So we'll have to wait and see when those infection control rules change, what that looks like. I suspect, the next couple of years, we're still going to see lots of things around backlogs needing to be dealt with, both within the council and within the NHS. So that, I think, we'll see winters becoming more difficult than they have been even previously, although they have been very difficult in the past. And of course, demography changes every year. People forget that, every year 2-3% more people are an aging population. also has an impact. So I think what we've got to be braced for more difficult sort of winter periods, but more almost as important is the ongoing quieter periods are also busier. So the resilience of the system needs to change all the way through and all year. So and I think what we're going to have to do within adult care is make sure that we carve out enough time for the strategic planning and planning for years 3, 4 and 5, because the danger is you will always be in crisis management, and we've had to do that during COVID for obvious reasons, but we also need to be able to make sure we insulate ourselves to make sure we're thinking through the medium and long term, because otherwise it's quite easy to get dragged into the operational, and if we know that's going to happen every year, we need to make sure we devise systems and structures that allow us to both respond and work to make sure we can respond better in years 2 and 3, if that makes sense, Paul.
It does, and thank you for all of those responses, really useful for me.
Thank you, Chris, very much for responding to Paul. Calvin.
Okay, thank you, Chair. Yeah, thank you, Chair. I guess there were two things that I wanted to raise. One of them, I think, is very much picking up on what Paul has just been talking about. And first of all, to thank officers for the way that they have supported providers over the winter period. One of the elements of that was the social care workforce support that we were able to provide with teams coming from our own workers, which was something I wasn't familiar with as a relatively new member of this panel. And given that the pressures in the future that Paul was talking about, we've been talking about, is that something that will be continuing? And how is that team? The other question around that was how that team is managed, and how the teams that those people are drawn from are managed whilst they're actually providing that support.
Yeah, so I suppose in terms of support with information, advice, guidance, one of the things we set up right at the start of COVID was the HCPA hub. So a joint venture really between HCPA, Hearts Care Providers Association, and ourselves, and we've manned that or personed it over the period. And there's been times when we've put more resource into it, and times when we've been able to scale down because things have been a little bit quieter. But I do think that's now an ongoing feature of how we're going to work in Hertfordshire with our providers, because it's been so well received, I think. So there's a piece of support that will become part and parcel of our ongoing arrangements. The outbreak cell, jargon, but the outbreak cell has been the team that's really tracked outbreaks and supported providers, relentlessly really when outbreaks occur, working with them ever so closely to sort of help them through that. And at the moment, we've got funding for that team for another year. And unfortunately, we're losing one of the leading lights of our COVID response, Anna Makepeace, who's going on to bigger and better things. But before she goes, she's sort of making sure we've got a good, stable arrangement that's going to see us through the next while. So, and we've made sure we've got sufficient kind of resourcing to cover that off as we go into the next year or so. And in quieter times, those resources can be deployed into other areas, such as supporting the monitoring and assessment of care homes, making sure they're following our quality standards. I can see that Chris wants to come in, Chris.
Yeah, and also there's, as Calvin mentioned, there's the social care emergency workforce team, the SKU team that you mentioned, which is in a sense us trying to have a number of members of staff that are ready to be deployed if there are issues with providers' workforce. And that's not a long-term fix, but it's around short-term issues. If there's issues around chronic issues around staffing, or if there were to be a significant provider failure that happened quite at short notice. So we've got some people that will have as kind of supernumerary working in our in-house services that can be pulled out if needs be. Clearly, their work needs to be done by someone else in those in-house service teams. But we have a bigger pool of staff that we can manage that risk for a short period while we manage more acute risk somewhere else. we will be keeping that kind of arrangement going and working on how we make that ongoing, an ongoing sort of part of our resilience response, Calvin, because we think it's important, because providers can face issues around staffing for any number of reasons, and the number of providers we support, we've got to assume that sometimes there'll be issues, and we want to have something that can provide short responses as perhaps we gather our plans or the provider gets back on their feet, and that's something we'd want to keep beyond COVID. So that's the idea with that team, and we're just sort of finalising how we operationalise that.
Thank you, Chris. Thank you, Calvin.
Yes, I did want to raise one other issue. We've talked quite a bit about recruitment and retention within the care staff, but I'm also concerned about that with our own professional staff and social workers. That is referenced, I think, in 5.3 in the report. And really, the question is: are there particular teams where there are ongoing long-term vacancies, and what are we doing to address those, particularly with the backlog, as we know in assessments and the backlog in our own work that COVID has caused, and how is that going to interact with things moving forward? I think there was a reference earlier to years 3, 4, and 5, but how is that going to interact with the requirements that we have under social care reform?
Chris, do you want to pick that one up?
I suppose just a few thoughts from myself. So we have had a very high profile recruitment campaign that we run. We had some additional grant funding from government that allowed us to fund that. So a bit different, a bit more hopefully attractive. I think in terms of Herts County Council's offer, as I talked about, I think when people join us, they tend to often stay around because from an L&D perspective, my view is that we're sort of second to none, really. And I think the culture that we have in the department is an incredibly supportive one. When people join us, I often hear, how great it is as a place to actually work. So getting people through the door, once we've got them, then they hopefully will stay with us. I think we need to think about how we grow our own. So we have had some apprenticeship opportunities. We have a lot of people coming in at what we call community care officer level. So they're not professionally qualified, but they're really interested in the sort of social care work. And often they're a really good route, really, for people to sort of take on and do that professional qualification once they've got a taste for working in social care in that sort of context. I think we need to grow that. I think the other challenge is making sure we're using that resource, that professionally qualified resource, efficiently. And that sounds, business-like in a way. But what I mean by that is that, let's make sure we're using social workers carefully, and they're doing the things that only social workers can do, rather than getting involved in administrative things that eat up their time. So I think we've got some work to do to really think about that as we redesign the social care front door. So we're doing a lot of work for the insourcing of the teams currently who work in the social care access service, which is delivered by Serco. Those teams are due to come back into the council's direct control as of April next year. So as we do that, we're really thinking about our business process and making sure we are, as I said, using social workers where they're absolutely key, and then have we got the right resource around them to allow them to be focusing on practice and on the complex issues that they need to be dealing with. So that's a key strategy for us. And as we look at care reform, we're going to need to do that even better and even bigger and at scale. Because we think that we'll be needing to work with more and more people. So, that challenge of how we use that precious resource really carefully, I think, is the answer to that. But lots of work to do to get us there.
Thank you, Helen. Thank you for that answer. Richard, patiently
Yes,
had your
thanks,
hand up for some time now.
Yes,
Thank you.
thank you. Well, yes, and happy to have held it for so long, because I think the questions and the answers we've received have been very enlightening. Mine is slightly off piste, and I'm not sure whether it's Helen or Chris would want to answer this, but it's triggered by the fairly the graph 5, which is the adults waiting first assessment, which clearly is high, and the report makes it absolutely plain what the pressures are and why across ACS this has happened. And clearly it would be a right surprise if it wasn't being reflected in our peer authorities and in other people providing outside. But do we have a handle on whether or not the percentage increase in Hertfordshire is any greater or less than our peers? And in other words, is there anything happening here that we ought to be looking at that might be able to allow us to mitigate the future pressures like this? And by the way, can I just say, I was very much impressed by the way that this problem had been identified, and the actions and reactions that you are putting forward to try and deal with it within Hertfordshire. So this is not in any way, shape or form a condemnation of the fact that they're so high, but a question as to whether or not there's anything occurring that we ought to be looking at to see whether we can control it better in the future. I don't expect we can, but there's the question.
Thank you, Richard.
I know there's a lot of comparative sharing of information about people waiting to be assessed, which is happening certainly regionally via the ADAS group. I know Alex is on the call. I don't want to put him on the spot, but I wondered whether or not we have that information, because it's certainly being called for, isn't it? And I haven't got on the top of my head where we sort of sit with that.
It's what I can say is we've not had results back from the latest regional ADAS survey, but what I can say is that everybody is feeling the same pressure on all fronts. It's different because what we submit is a total number, and we're a big authority. Some of the other eastern regions are slightly smaller, so they report smaller numbers, but it's still very much a similar pressure across the region for those waiting for assessment, as well as those waiting for services, and in that kind of chart that Helen showed around uncovered packages of care as well. But yeah, it is something regionally and something we could probably share if we want to. I think it is published by ADAS each time they submit it as well. Sorry, no, Chris is there as well.
Thank you, Alex. Chris.
Yeah, it's a really good point, Richard, and thanks, Alex, as well, and Helen, for that. There was a ADAS, for the members that don't know, is the Association Directors of Adult Social Services, so my equivalents in the other 150 councils. A specific survey was done this year on these issues, which was around what those waiting lists for assessments or for care were, and a report was done on that. We'll get that sent round. We'll get the link sent round, Richard, so you can say that. So yeah, but bluntly, we're about, from what my analysis of that is, we're about in line with everyone else on this, because the pressures we faced aren't unique around COVID and around the workforce and so forth. In fact, some of the workforce pressures around care workforce, not our in-house workforce, but the wider care workforce, we probably felt earlier in the Hertfordshire and in the wider southeast region ahead of other areas. We probably felt that earlier than others, and that's been an issue over the last 3 or 4 years. So we're certainly not an outlier. What we need to do, and I think what Helen brought out in the report, is what do we do to manage risks within that environment of people waiting longer than they want to, and that's about saying, well, actually, triaging people to try and pick out those where urgent support would prevent issues getting worse, and therefore being a bad outcome for that individual, but also creating more work and resource for us later down the line, which is only going to make the delay that getting on top of this. So, I mean, it's obviously begun to go in the right direction, and key really is recruiting enough people in to help us do that. So actually, it's not a financial issue. It's a workforce issue in terms of getting the people through, but also each time we have a wave, it's delayed us being able to respond to some of this in the way we want, because we've had to respond to the acute pressures that the wave has brought and doing our part in terms of that response. So it's something, Richard, that we want to keep a very close eye on, and we've taken financial investments to move it. It'll take a while to move, but we're keeping a very close eye on it, Richard, and constantly, it is on the risk register now. Had a report to the audit committee because we want to be transparent about the issue, and about the work we're doing to manage the risks and bring those weights down. But it's very similar in a sense to the issues around NHS backlogs and waiting lists and so forth. So we're doing everything we can to do that, and we thought it was important to be as transparent and open about those issues as possible.
Yeah, Chairman, can I just come back? I mean, yeah, of course, that's fully understood, and I'm delighted. But I go back to my point. This is not in any way. Let me say, it was a graphic graph, but I wasn't surprised to see it, given the way that the report clearly outlined the pressures that had occurred. What my concern was, Chris, is that is there anything happening in Hertfordshire that is creating a bigger, a worse situation than our peers? Clearly there's dialogue going across, and that satisfied me, and it'll take a while to sift this out. But it's just if there are things happening in Hertfordshire that will continue to bear down in future waves in a disproportionate way, and we can do something about it, it would be very sensible, because it looks like you're trying to head off at the pass all difficulties coming forward, and it's just another one that I just thought ought to be in the mix, and clearly it is, and I'm grateful for your answers. Thank you very much.
Thank you, Richard. We have no further hands up. Are there any further questions that any of the panel would like to ask the team while we have them? First of all, before we note the report, I'd like to thank Chris and Helen and everybody as part of this amazing recovery team. The winter, I've been working closely with them. They have worked day and night relentlessly, and none have ever put forward a jot of complaint or anything. It's absolute support they've shown along the way, and I feel very, very secure with this team, with them going forward, that they will keep that ship in the harbour and it won't be floating off anywhere, and will keep control of everything. They have a challenge every day, every minute, every hour, and the recognition of that is there in front of us. Panel, I'm going to ask us now to note and comment on the summary of work that's been managed through the winter period and the Omicron wave of COVID, the strategic risks as we exit from COVID, and we are exiting, and the mitigations and recovery priorities as described and discussed this morning. Could we note and comment on that in the chat box, please? Thank you, Ron. Colette. Rena. Tony. Thanking you, panel, very much. Item 3 has been agreed. Moving on to item 4 now, Adult Social Care Performance Monitor for Q3 21-22. And Alex, who came in for a short time, is on the previous item, is going to present to us. Alex Ogle, ACS Performance Manager. Thank you, Alex.
Stella. So just before I start, this is obviously Q3. We're a bit beyond that because I think we were due to come to panel a little bit earlier. So it may seem a bit strange that we're sort of talking about data up to the end of December and we're in April now. But what I'll try and do is some of the kind of statements that are made throughout the report, I'll give you a little bit of an update verbally about where we actually are now, if it makes sense to do so. In fact, that very first statement there talking about new requests for support to the council, as at the end of December, we were still a little bit lower overall in regards to new requests coming than 2019-20, so pre-COVID. But actually towards the end of the year, as we got up to the end of the March, we're actually just very slightly higher. So requests have started to pick up this year in the data that we're about to report to government from a front door perspective. So those numbers that are there at the moment, showing slightly more for 18-64, have remained high for adults aged 18-64. Slightly lower for 65 plus, are actually slightly higher now as we went to the end of March. So actually overall, we've had higher volumes of new requests for support this year than compared to actual pre-COVID levels. Reflecting on that as well, that was an increase overall this year for support from carers. And I think we said every quarter as we've gone through this, from a carers perspective, we've been doing more assessments this year for carers. When we get to the carers direct payment slide, which is further down, I've done a bit of a chart that shows that kind of trend of carers assessments over the last few years. And it's dropped slightly as we went into sort of December, January, March, February, March time. But definitely from an overall point of view, a much larger volume of carers assessments coming through the system. And there is a bit of a reflection on that. And Chris was alluding to some of we were talking about the waiting lists earlier. But we've had a lot more carers come through, and that's had a slight effect on waiting list numbers as well, because we've had that kind of increase in carers coming through as well. And it's worth saying as well that, you know, feedback from services is that, and regionally, to be honest, from my colleagues and other authorities, is that complexity levels are higher as well. So when we're actually assessing adults, we're seeing that those levels of assessments are more complex as well. I think Helen had some of this in her report as well, but we've talked previously this year about home care capacity growing significantly. That's still the case. We've still got kind of higher numbers of adults receiving home care. The numbers of hours being delivered are higher as well. And we talked, and Helen had another slide in her pack there as well earlier about uncovered packages of care. So I know I've got here a statement of the 31st of January, that was 211. As at the time of reporting this week, that's actually 217, with actually nobody as of this week in the community without any support waiting for a home care package. But that's been monitored there as well. And I know, like I say, Helen's report had some of the latest figures on there. So we're slightly higher on those unfulfilled packages at the moment, but we're always kind of low on those numbers of adults who are actually in the community with no support at all. Direct payment performance is improved. We've got the slide on there, and there's some kind of background to that. We talked about lack of capacity there, but there's also been some other differences this year and changes that have driven the performance, and I'll talk that a little bit more when we get to that slide. And what we've tried to do in the last couple of quarters, talk a little bit about reviews there. So that last paragraph there talks about those adults that reviewed. So we have a statutory obligation to review adults in long-term services once a year. We do want to aim high. We can struggle with that, and we've done a lot more reviews this year and in 2021, planned and unplanned due to COVID. And we've been doing a lot of work in our ADS teams and across the services, older people's as well. So at the time of reporting, about 66.9% of adults had received their review in the last 12 months. Now that might mean that some were in the process of review at the time we reported this, but we're expecting that to be nearer and hopefully above the 70% mark for end of year reporting, which we're just working through at the moment. But a lot of work's been done around reviews and trying to ensure that's also reflected effectively on the system for us to kind of report back to government as well. And I think you'll find that actually it seems strange. It might seem strange to say, why isn't that 100%? But like I said, some might be in under review as we speak. And actually nationally, probably about the average is about 63% of adults receive a review every year from the other 152 authorities. And regionally, I think it's about 65%. So we tend to be slightly higher. And like I say, hopefully we're going to finish at about 70% for that figure as well. Okay, so the first one we'll look through, hopefully you can see this well enough. Let me just zoom out a little bit. Is paid employment. So this looks at adults with a learning disability who are receiving a long-term service with HCC, adult social care, and whether or not they're in paid employment. We talk about this a lot. It's dropped slightly to 6.2%. We'd set a target this year, which is going to be, we think, the same target for this financial year, at 8%. And a lot of kind of work has gone in through funding, which you'll find in the commentary around the European funding, as well as specific positions in our adult disability department to try and drive up those employment figures. It's a difficult area, just the LD area. We have, complex LD adults within Hertfordshire, and there is a lot of talk, and I think I've said previously about expanding the remit of this particular indicator nationally to include adults with physical disabilities, focusing on those adults that are in voluntary work as well, because it has the same positive effects that this indicator is trying to measure. But a slight drop, and I think we're going to finish at around 6.2% for the financial year as well. We generally, and we talked before again about the different figures across our services. So, our adult disability services are slightly older adults that are sort of 26 to 64 have higher proportion of those in employment. So Hearts Valley is about 7.7%, East and North 6.2%. We struggle a bit more with the 0 to 25 service, so that's our 18 to 25 cohort, and that is mostly because most of them are in full-time education, and then it's harder to get them into kind of paid employment on that front. And then again, following previous requests, we've got a kind of breakdown of the kind of hours worked for those that are in employment as well, and I've split that by the kind of age bands as well. Okay. The next one we've got is those leaving hospital, those older adults 65 and over leaving hospital and going into our enabling style care service, who are still at home on the 91st day. So complexity of this one. So basically they've left hospital, and on the 91st day, when we've kind of followed up with them, they're still at home. They're basically not in a residential or nursing setting or back in hospital. Or passed away in that time. So it tries to monitor the kind of success of that service following the hospital discharge. We've been doing quite well this year, towards the end of the year, so it does fluctuate throughout the year. When we get measured on it nationally, it focuses particularly on the October to December time period, so that in theory what used to be now, but the kind of high level winter period, the peak of the winter period. And I know for now, so we had a slight drop into Q3, but I think we're going to finish on around 86%, which is quite high performing compared to our comparative authorities in Eastern Region as well. And generally, from the breakdown point of view on that front, about 86%. And better performing areas are for female adults. We obviously support more female adults, but we tend to have a higher success rate with female adults going into that service post-hospital discharge. And just more widely on our enabling style care. So that is, just to explain, it's 6 weeks of care or up to 6 weeks of care with sort of focused interventions to try and get the person back on their feet and independent again. Generally, about 80% of those adults that go through that service have a successful outcome. So that means they go on to receive no further service from the council, or they get a reduced package of care as an outcome. So we've, that's kind of seen as supporting them to be independent again. Direct payments, which I kind of referenced at the start. So as of Q3, we're at 27%. And we've got a bit of a breakdown by the services there. We have had really high improvements, strong improvements in this performance indicator. It's a national indicator. A direct payment is basically those adults where we've had a discussion about a personal budget with them, and they've chosen to take that personal budget in the form of direct payment to go and pay for their own choice of care, rather than us arrange that care directly for them. It was meant to be seen when it was created as this kind of ultimate personalization approach for care. It has its benefits and disbenefits sometimes, but we've seen an improvement throughout the year. So you can see we've got 26% in Q1, we're 27% in Q3. We're actually at about 28.7%, we think, for the end of the financial year. And I think we discussed previously that's been driven a little bit potentially by capacity in the market, and adults actually taking a direct payment instead of a directly commissioned service. But we've also had kind of increases in areas such as Stevenage, where new home care providers have come on and adults have chosen to stay with their old provider, and we've provided a direct payment in place of that. So we have seen some drivers that have improved that performance. But nationally, if we finish on about 28.6%, that'll be the best performance we've actually ever had for this national indicator. And we've kind of pushed that even further in target setting this year to try and achieve 30%, which will push us right up in the rankings nationally on the indicator itself. Apologise if I'm rattling through this. I will take any questions and skip back. Carers direct payments, we performed really well on this in the last 2-3 years, and there has been general improvement across the board. It does tend to increase throughout the year. but we're on 77.2% for Q3, and we're near a 78% of carers on a direct payment by the end of the financial year. Again, similar to the service, the adults direct payments, it's carers we support who choose to take that personal budget in the form of a direct payment. It doesn't necessarily mean that kind of 20+% are not being supported. It may just mean that they've chosen to take a carer's break or a respite. We don't call it respite anymore, I don't think, but a short break in place of a direct payment. So they're still being supported. They just haven't chosen to take that as their kind of direct payment to go and search for care themselves. But generally, performance on that's improved. We do better, as I've said before, on this kind of younger adults in our 0 to 25 service and our adult disability service. And it's a national picture in the same way. Those older carers, and same for direct payments, older adults around direct payments, we tend to have less uptake in those age groups and services. We then move on to kind of residential and nursing admissions. So this is an indicator that looks at new residential and nursing placements that adult social care put in for our adults. So for our younger adults, which is this one, which is 18 to 64, we've had good performance. Pre-COVID, we sort of sat around the 12 per 100,000. So it's about 80 placements, 80 new placements for adults aged 18 to 64. During COVID, obviously we had a big drop. And we've kind of maintained that performance. Now, it's not only COVID that's had an effect on that. You know, there is always a drive to go to residential nursing. It's not necessarily a last resort, because if it's the right thing to do, it's the right thing for the person. But we look to support more independently with things like supported living services, flexi-care, obviously enabling style care to support them at home for longer. So there is drivers from that point of view as well. But from the 1864 cohort, you know, we're on target. We'd set a pre-COVID target of about 11 per 100,000. And you can see there for Q2, we do this a quarter in arrears, but we're about 8.7. And for the year end at the moment, we're projecting about that kind of 8.79 per 100,000 mark, which is about those kind of 80 admissions. So we're still maintaining good performance on that one. For the older adults, again, we'd set what was a stringent target pre-COVID. We hadn't sort of pushed ourselves beyond for the last financial year for 21-22, because obviously COVID had a major effect, and we were waiting to kind of see the to a certain extent that settle. But we'd still set that kind of 500 per 100,000, which is about 1,020 residential and nursing admissions. At the start of the year, we were projecting a really high volume. And that was affected by our discharge to assess service and adults that were sitting on that service that were then coming off into new long-term placements for residential and nursing. But throughout the year, we've actually seen that drop, and the new placements have dropped bit by bit throughout the financial year. And sorry, I will scroll down so you can see the monthly volumes here. So you can see here where we were pre-COVID, 2019-20, in that sort of 80 to 100 per month, and that's actual placements. Had that big drop off as COVID came in. Increases towards the start of the last financial year, as we talked a little bit there about discharge to assess services post-hospital and the effect that was having. And then you can see again, we've kind of had a bit of a drop off as the year has gone. And I think, to be honest, by the time we've done our final submission to government for from an activity point of view, we'll probably sit under that target of 500, about 490, which is just under 1,000 placements this financial year. And I think we're going to be a bit stringent this time and focus on a stretching target to try and maintain that moving forward as well. And then the last one, I apologize, because I know you had an additional slide in here around safeguarding, so I apologize if you've got that and I'm confusing you a bit with the slide here, but I've got Stephanie to update the link post the session. Again, we're looking at learning disability adults on this one. So this is those at home, living at home in their own home or with their family. So this again is a measure around independence for adults with a learning disability. Again, over the last 2 years, performance, and I'll scroll down a little bit, hopefully you can see a bit of the chart. Performance on this has improved in the last 2 years. So if you have a little look at where we were in April 19, about 77.7% of our LD adults were living on their own or with their family. That has just increased bit by bit up to 79.3 at the end of December, and I think we're going to finish a little bit higher than that, almost 80%. There is a brick wall, should we say, because we do have LD adults in residential and nursing, and then they automatically fall out of this indicator, and I think that's about 19% of adults, LD adults in residential and nursing, so we can't really go beyond sort of the 81% mark anyway. But generally, that performance has improved bit by bit throughout the last few years, and we're hoping we're finishing about 79.8% for Q4 as well. So there's been some really good improvements there. Younger adults, you can see our 0-25 service, even better, 86.3%, slightly better in East and North than Herts Valleys, but generally performance on this indicator has improved quite a lot over the last few years. And then the last bit is just a bit of a reference to safeguarding concerns. So we're projecting, and I think we're going to finish around this, about 7,977 concerns for safeguarding this year. We've leveled off. We had a bit of a kind of an introduction of a professionals portal for safeguarding at the start of 2020-21, and just into 21-22. So we saw I suppose an improvement in recording of concerns, because professionals have to go through the portal. They're asked the kind of key questions about the safeguarding episode, and it kind of makes sure that the only episodes that are truly safeguarding end up with our safeguarding team to kind of progress to concerns. As well as COVID, we've seen a kind of leveling off, so you can see our projections are not far off, slightly higher towards Q3 for concerns there, and then that darker bar is the number of cases that go on to inquiry, so actually have an investigation take place, and that's about 50% go on to investigation. And a bit of the right hand side there, you can see a bit of a breakdown. So for majority of those take place in the adult's own home, followed by residential settings, residential nursing settings, 26% in residential, 12% in nursing, and then that's followed by hospital settings. And most of those types of abuse and neglects and acts of omission, followed by physical abuse and then psychological abuse. And we have seen an increase towards this during this financial year and under COVID around domestic abuse, and that's 9.5% as at Q3. But domestic abuse, I think we're getting closer to around 11% of types of risk reported under safeguarding a domestic abuse at the moment. Apologies, Stella. I know I kind of rattled through that a little bit and tried to link into the later data.
Doing a great job.
But any questions on any of that, I'm happy to answer.
Leslie, you have your hand up.
Yes, thank you very much. It's a really interesting report, and it's good to see where we are in comparison to other areas, etc. I'm particularly interested in the learning difficulties adults in the paid employment, and the fact that the number of them went down. Wondered how much of that was due to COVID and shielding, etc. Because obviously they have often complex needs. And also, is there any way we can get the number of hours they do improved at all, or is it limited by their particular disabilities?
I'll answer a couple. There's probably a couple factors that have affected it, and Chris could jump in as well if you want to, Chris. We have done some cleansing work this year as well. So we worked with our skills, Step to Skills service, which used to be our work solution service, which supported those LD adults that aren't necessarily eligible for support. But we've worked with them to kind of review this, and you are meant to do that each year, review those that are on our system as in employment. And yes, possibly there is a slight effect from COVID and those being able to get out to work. But we also know that we've kind of caught up with people under that time period and caught up with the fact that they're no longer working. So we've seen a slight drop there as well.
Thank you.
Around the hours, I don't know if you've got anything to add to that, Chris, around the hours part.
Yeah, I think you're right, Leslie. There's really a couple of issues there. One is some people's reluctance to be out and about during the period, the heightened potential impact of COVID for individuals with a learning disability, number one. Number two, obviously we had sort of profound changes to the economic environment and what companies were running and what weren't. So a bit of a kind of odd 2 years, really. So in some ways, I'm quite pleased that performance has held up as it has. You know, come what may, the focus needs to be on more people securing paid employment, and that's the kind of commitment that we've got to move that forward, and hopefully we're in a position where the economic climate around lockdowns, etc., we hope is over, and albeit clearly other economic factors at play, but yeah, our key aim of supporting more people into employment remains.
Yeah, thank you. I'd just like to add that it's great to see that you've got so many of them living with family or supported, and I'm really pleased to see that, because those particular adults often seem to get missed out within society. So that's really good to see that they're doing so well. Thank you.
Thank you, Leslie. Nigel.
Thank you, Chair. Yeah, thanks for the report by Alex, but I'm particularly concerned as ever with obviously I know it's the last thing you looked at, but the safeguarding concerns, 1.7. Obviously the 50% in the home. I know it says 12% in the nursing home, but what are we, I'm going to presume obviously we're working with police and other agencies as much as we can, I think you said that the figure, compared to 19 maybe is stabilized. I don't know, but I'm still, concerned that this obviously is going to be always coming up. But what we can really do to really try and get that a better, more respectable figure, if you like, try and get it a lot down. But is there anything else that we can? Can you?
Yeah, I can hear
Nigel, you're coming in and out.
Oh, sorry. Just on the safeguarding concerns, I'm still concerned at those figures, and what I presume we're working with the police. Is there anything else we can do to really get that a better figure there?
Yeah, I'll take that one, Nigel, if you want. Yeah, so it's one of those indicators where if it goes too low, I'm worried that we're not having the safeguarding issues presented to us, because obviously clearly we'd rather know about them so we can look at them and manage them, and they went down during the lockdowns for a variety of reasons. So I'm in a sense pleased that they're going up, because I'd rather be aware of issues than not be aware of them. It's also important to state that a safeguarding concern can range from physical abuse to an act of omission or neglect. So the kind of each one's serious, but the severity can range within that. I think overall, one of the things we do is where we see themes around safeguarding. Let's say, for example, medication errors that providers may be carrying out. We all then look to say, well, okay, what's the training we can give to providers to help their staff around medication management? If we spot that being a continued issue with a specific provider, clearly we'd work with them. Ultimately, we can go through more formal measures with those providers if those issues continue through our service improvement process, and we can then use contractual measures or engage in CQC if we need to. So we've got ways of dealing with it on a kind of provider by provider basis. Clearly there's issues around domestic safeguarding issues, so not a care provider, but individuals known to the individual that's been subject to a safeguarding inquiry. We have seen some themes that we're looking at. So we've seen some related to dementia, for example. So one of the things we would do through our Safeguarding Adults Board is bring agencies together to look at the trends. What is it that we can do? Is there stuff we can do around education? Are there service gaps? Are there things that we can do as a result? So what we do is we monitor that data really carefully to look for those themes, and then put in things to prevent those happening, or doing everything we can to prevent them happening, Nigel. So not in this panel, but obviously operationally, we drill down into that detail quite regularly. We also do a quarterly meeting with the leader and the chief exec and the exec member, given the importance of safeguarding duties for the whole council to do that. Most importantly, though, I think is the close working with the police, health colleagues through the Safeguarding Adults Board that, as you know, Liz Helen chairs, who's an independent chair that offers that scrutiny.
Thanks.
Thank you, Chris. Colette.
Thank you, Chairman. Leslie covered almost everything that I was going to ask, actually. If I can make a comment, I think it's vital that we do monitor those performance figures closely, because we know that when we have got people with learning difficulties into employment, it helps every aspect of their life, and actually can reduce costs all round for various agencies. So I'm just saying thank you to the team for the work you're doing, and you know I'll be very interested to see this reported back at a later date. I shall read it anyway, even if I'm not on the panel. But thank you.
Thank you, Colette, for that. Thank you very much. Richard, your hand is raised.
Yeah, it is. I was trying to operate the on switch. Thank you very much, team. Excellent report, as so many always are. My question is around Agenda Pack page 39 and the fairly stunning report that better than 10% of the adults discharged into reablement in the quarter up to the 30th of September were dead by the time the 91-day period had elapsed. Now, given the possible implications and ramifications here, I can clearly understand why the recognition of this is, how can I put this, Chairman? Guarded language, I think, is the wording I would use. Clearly, officers have picked this up and clearly are concerned and have got to be careful. But I notice the last paragraph of that particular page that a system-wide out-of-hospitals pathway demand and capacity review is reaching conclusions. And my question is a very simple one. When will we see this? Because frankly, it would seem to me to be a matter of immense concern on the face of it.
Thank you, Richard.
Can I just get Alex to clarify? Can I get Alex just to clarify the data point on that, Richard, and then I'll come in.
Do you mean around the deceased adults?
Yeah. Yeah.
Well, the data which I've got here, Chris, is essentially there were 789 adults aged over 65 discharged from hospital into reablement during the period the 1st of July 21 to the 30th of September 21, and of those 81 were reported as deceased after the by the elapsing of the 91st day, which is better than 10%. Worse than 10%. Better is not the word I want to use. It's better than 10%. And clearly officers have identified this, and I go back again to my use of the word guarded language. I can understand why. I want to know when we're going to see this report, and because it's a matter of immense concern to me.
So, I mean, well, clearly any individual deceasing is a matter of regret. Obviously, that's clear. I suppose one of the things that we are keen to support is sometimes, we measure as a system where it's best to manage people's end of life, and often people's preference is for that to be at home, and to be not in a hospital environment, to be somewhere where they know. So sometimes we're keen to give everyone the best possible chance to re-able and to get better. Sometimes that doesn't happen, and we're talking, the average age here will be really quite high of this age group, probably mid 80s, if not higher. And sadly, then that is associated with significant mortality post hospital discharge. So we do monitor it closely to make sure those trends aren't changing, but clearly we've also got other targets as a health and social care system about people dying in their preferred place of death, which often is not in the hospital, Richard. Where the demand and capacity work that you're talking about, we should get finalised. I don't know if Helen's on the call, but we're looking I think at next month, so May, for that to happen. That's to say, well, where do we invest in the right post-hospital pathways, Richard? So what money from government for discharge to assess has come to an end. So we're looking at, between us and the NHS, what are the best pathways to have to support people outside of hospital, including end-of-life pathways and hospice care, etc. Where do we best place the money that we do have in those pathways? What works best, what doesn't? So we need to make sure that's in place for Q2 of this year, because that's when we will need to make sure those new arrangements are financially sustainable. So I think if Helen's still on the call, I think we're aiming to get something agreed in May on that, Richard, which gives you a sense of the timescale.
Just to come in, yeah, that's right, Chris. And I think generally view would be we want to be able, if we possibly can, to sustain our investment in these enabling services that do get people home, which is all about, you know, meeting people's preferences really for where they want to be receiving care and support.
Chairman, I do fully understand, which is why I was so careful about the acknowledging the way in which officers had identified actions over this, and you know, guarded language is the right thing to use, because there are so many implications, but so many ramifications. And if someone says, "Look, I don't want to die in hospital, I want to come home," then clearly that's their choice. So I'll look forward to that report in due course with interest. Thank you very much.
Thank you. Thank you, Richard, for your question. Paul, your hand is raised.
Yeah, I know Ron's hand was up before mine, and that he leapt out for a second. It might be that he has something to put in ahead of me. Should I just offer that up to Ron, and then I'll come back?
No, you go ahead, Paul. So I'm happy.
Okay. Mine are just a couple of very specific points about 1.1 on employment, which we've already covered, and I just wondered, it's amusing really that it might have been particularly difficult in this COVID period to get these adults into employment, given the difficulty of doing face-to-face training, and maybe that's something that when COVID, you know, as it moves away, will become easier for us, because obviously we've got a kind of a tighter labour market, so there may well be some employers looking to cast their net more widely in terms of employment, but I imagine there may be a higher training need for them, which would be face to face, than just as we've seen with some people recruited to a new job and started, you know, working away from home from the first minute. So that was just an observation. I don't know if you have a view on that, if anyone has a view on that, whether that would give us encouragement for going forward.
Yeah, I think so. I think, you know, there's an issue around when we were dealing with lockdowns, furloughs, etc. The capacity of employers to take individuals on in this cohort would probably have been constrained, one would imagine, because of the nature of the other things that were going on. So I would expect that to change, and face-to-face training is a good example of that. But also, you know, the acute employment challenges within the labour market means that employers are going to have to look at every possible angle for support and in encouraging people into their workforces.
Thank you. My other point is actually something that just struck me as a quite a significant and a success. I think it was 725 adults being helped by this project, 2.8 million, I believe, the 2.8 million project, which is running through European structural funds. So I'm just wanted to check that, given the new circumstances, that all that money has come our way and doesn't disappear because of our different status as a country. I'm just surprised to see we had that money at this stage.
Yeah, we still got that. Yeah.
Okay. Well, that's good. That's encouraging. Thank you.
Thank you, Paul. Ron, I'm going to.
Thank you, Stella. Yeah, could I just? I've got a question and then a comment on something, but can I just go back to this European structural funds? I don't know whether it's possible to find an answer today, but I read something in the last few days about the fact that the government's package towards areas which would normally have received European funding is actually less than expected and is not likely to reach the required target until about 85, 86. Now, if that is the case, would that impact upon anything that we're doing? So that's a speculative question based on something I read the other day. But I don't know whether somebody wants to pick that up or just say, sorry, we haven't got the detail on that one before I go on to the 2 points I wanted to make.
Okay. Chris, what's your thoughts?
Well, so the funding on the as I said before, we've still got that funding around that programme, which is positive. Obviously sort of aware broadly around the different funding streams that are coming through. None of them were directly for adult care, Ron. They would have been for the wider local authorities and councils and different new funds coming out of government. So I'm not in a position to comment on the value of those compared to previous funds or anything like that. But I do know that officers across councils and districts are working on what that funding might mean, or not from Hertfordshire, as it relates particularly to the government's kind of levelling up agenda and white paper that was published earlier in the year. So I can't comment specifically, I'm afraid, but happy to take a question offline, Ron. I can get an answer from other council colleagues if it helps.
Thanks for the additional information. I know Cornwall looked specifically, Cornwall and other areas like Cornwall were likely to be specifically hit by such factors, so it may not necessarily affect us. Going on to my proper questions, if you like, the ages of carers, unpaid carers, have been increasing gradually over the last few years, and it remains a matter of concern. And I just noted in the introduction on page 4, there's a comment that in actual fact we had more carers asking for requests, asking for support and assessments in this last period. And I just wondered whether or not that reflects COVID, or it reflects the growing age of the carers themselves, or what trends can we identify from that factors? Because it obviously, as they are a main area of providing care for people, for them to start to become vulnerable is a worry.
I think it's probably one. We think it's both. So every year we've got aging population, both older people's populations, so a great people are living longer, and life expectancy goes up in the general population, but also, as you know, great news that people with a learning disability are living longer. That if they're being cared for at home, as Leslie mentioned earlier, their carers are therefore getting older as a result. It's why it's important that we have contingency plans for those arrangements. So that's one of the reasons. The other one is, yes, we do believe COVID has an impact. So COVID was really, really difficult for unpaid carers because of lockdowns. We did our best to keep as many services to support individuals open as possible, but obviously people were taking decisions around the potential risks of being out and about because of people's relative susceptibility to COVID. So that placed a quite significant extra workload on carers. So I think some of that we're now beginning to see in requests for assessment. And again, a bit like safeguarding, I'd rather have the requests and understand how we can support and do that as early as possible than for those situations to be put under such strain that they break down with poor outcomes for everyone involved.
Thank you very much. And finally, just a comment, when Alex was mentioning the various groups in the learning difficulties in employment, paid employment, I don't think, or I didn't hear him mention full-time employment for the full-time education for the over 25s. I've always considered this measure meant to be also one that looks at the well-being of the individuals as much as an economic factor, because obviously if they're occupied or gainfully occupied, even if it's unpaid, then that does their mental health and well-being a lot of good. And so I think it would be useful if we could include any of those that have actually taken up full-time education or training opportunities online or in any other way as an indicator, so that we can see whether or not that is a growing area.
I'll just say quickly before Chris comes in. So yeah, we have. I mean, I think we put it in the commentary before. I don't think we had it in this version. Apologies, but yeah, definitely for that 18 to 25 cohort, the main reason they've got a lower employment rate is because of that education. And you're right, Ron, that the indicator when it was created 8 years ago now, almost 9, was meant to be about that kind of well-being point. But you're right, and they are under review this year. I think personally, which is why we include things like the voluntary work, because that provides exactly the same kind of support and well-being factors. In the same way, it's not a negative that they're in full-time education compared to full-time employment. So definitely we can follow that in the Quarter 4 report and refresh that. And I think at the top of my head, I think it was about 70% were kind of in education and not employment from that age band. But you're right, definitely there are other factors, and they're definitely considering that nationally at the moment about what else should this include, because it is all about the well-being of those adults, and actually just focusing on those in long-term services with a learning disability in paid employment, full or part-time, is not really a full picture of those that are being well supported by the council through different routes. That makes sense.
Yeah. There's so many opportunities on the internet these days for learning all sorts of things, and which could keep someone connected with the rest of the world.
Yeah.
Anyway, thanks, Alex. Thank you, Chair.
Thank you, Ron. Good point raised. Nice. Ron, you continue to have your hand up.
Right, I'll take it down now.
Thank you. Panel, I see no further hands up, so I'm going to invite panel to note the report and comment as stated on the Q3 performance. Thank you. I'm going to change my screen.
Oops, mine should be noted, not notes. Apologies for the typing.
I think we know that what you mean, Ron. I won't assume. Thank you, panel. Item 4 is noted and agreed. Moving on, thank you for the engagement on that on the previous item. Other part 1 business, no other part 1 business has been notified. And I'm going to now, the date of the next meeting of the panel will be the 17th of June at 2 p.m. I'm going to thank you all so much for your time this morning, for your energy, and wish you a good day. Take good care of yourselves. Look forward to seeing you soon.
Goodbye.
Bye-bye.
Thank you.
Thanks very much.
Thank you.
Thanks, colleagues.
Bye. Thank